Thank you, sir, for this wonderful introduction. I would also like to thank Natarajan, sir, also, and the whole team for giving me this opportunity. So, AI in diabetic retinopathy and ARMD. So, the next few minutes we are going to see on the objectives. Is it just the hype, my dear friends, or is it a real McCoy? And how did we, or myself and my team, construct an AI from human inspiration? And how did we create our toolbox? So when we started people talking on AI, it was so fascinating. It started from the James Cameron movie Terminator. Is it something that is real or hype? Is it something that is just people talk AI, AI? Is it something that is real? Yes, my dear friends, it is real and happening, and it has revolutionized our lifestyle. So let us see this video. Unknowingly, every day we use AI in our life. We unlock the smartphone with our AI, the face recognition. We use our fingerprint in our phone. We use the fingerprint in our laptop. And also, recently, I had the opportunity to drive a Tesla, and actually, it's a very beautiful car. Actually, now it's not launched in India, but it has a LiDAR sensor, and there are a lot of AI vehicles coming into play. That the vehicle knows when to stop, where to stop, which signal to stop, when there is a roadblock, when there is a person crossing. So these are things which are very, very fascinating actually. And there is recently a NASA's first unmanned aircraft. So when we talk about AI, it is actually around us, even the autopilot that we are all going in daily. But why ophthalmology, my dear friends? Ophthalmology because it is an image recognition field. Ophthalmology is an image recognition field where a lot of images, especially the fundus photography, the OCT, and when it started, there was a pseudo scare whether AI will actually overtake us. Can I have a pointer? So, but what I understood is there is just a pseudo scare. There is never ever arm wrestling. It is just that the doctor and the AI tool working together for a better humanity. So this is a publication of ours in the IJO April 2022 issue, an original article featuring how human intelligence can augment with artificial intelligence. So because the humans will always have a role. So this, my dear friends, is the CNS and the PNS nervous system, where you can see which is mimicking the, can I have a pointer please, which is mimicking the artificial intelligence algorithm neural network on the right, shown by the red arrow. It is similar to the CNS system that we have made. It's called human in the loop learning. It also has to undergo a birth from a child to an adult, just like a human. So you can see in this figure, this is a normal fundus. So this is like a normal baby. So now we have to teach what is a diabetic retinopathy, and that is again another original article of ours which is recently published in 2023. How did we customize in making an AI? Because the AI has a black box limitation or a black box dilemma. The rationale behind the predictions of it are not fully known. Why it predicts the way it predicts? To overcome the black box dilemma, we use this convolutional neural network approach, just like the anatomy. Not only the diagnosis can be made, along with the diagnosis, you can also get the findings. So we had to annotate with teaching tools. So annotation means you can see if this is a fundus image, we not only say this is normal, we mark the optic disc. You can see here, we mark the macula, we mark the fovea. You can mark every structure. So you can mark what is a normal vessel. So these are all the human marking that happens. So this is a microaneurysm that is being marked. This is a atrophy that is being marked or exudates. So every single structure, a single image may have to be spent more time in annotating and marking. So you can see again here, you can see that there is a splinter hemorrhage that is being marked as we speak. And you can see again every different structures or every findings, not only the fundus as a whole, but every simple structures are marked. A cotton wool spot, the PRP marks, the new vessels. I started late. Yeah, I hope you can understand. So you can see again every structures. If this is going to be a fundus, there is holistically marking has been done, complete marking. Every single findings and every full structures are marked. The more the marking, the more predictions can be achieved. And this is the data that we published. And you can see this is how the fundus images are annotated, and then they go into the AI toolbox. Then the predictions are done. Again, the humans will validate. Humans will annotate and humans will validate. There are two human interfaces making human intelligence in play along with the artificial intelligence. So now the model is fully grown, and you can see that the sensitivity and specificity we currently have reached around 91%, which is very good. So these are some of the data that is shared from my publication, where you can see how the data in 2D and 3D interpretation, and even in mild, moderate, severe NPDR, and also other findings, we are now moving apart from diabetic retinopathy into other data as well. So finally, when you see the predictions, not only the diagnosis is arrived, along with the diagnosis, even the intricate findings, where there is a dot blot hemorrhage, where there is a neovascularization, and even wrongly marked findings also will be arrived. This is a wrongly marked finding, you can also avoid it. So that, my dear friends, is very important, and this is the algorithm that we have developed, and now the baby is up and running. You can see this is how the computer will detect it. It detects it like a blue and green. And see this animation, my dear friends. So first it will try to run, whether it's a normal disc or whether it is a normal vessel, whether it is a normal macula or whether it is a normal background. Then it will try to run whether it is a diabetic disc or a diabetic macula, or whether it is a diabetic vessel, or whether it is a diabetic background fundus. So once this is run, a clear line is now arrived. You can see now a clear line is arrived, and it separates this fundus into two. So which was normal or abnormal, now a clear line of separation is done. It's called support vector mechanisms. So you can see now, along with the diagnosis, also the intricate findings are arrived. So this helps us to create an explainable AI. We did not have an explainable AI, but now an explainable AI is created with 81% sensitivity, and we have a specificity close to 100. So we are moving with this feedback mechanism with the humans. Currently, we are using high resolution images, but with low resolution images, this may not really work out, but we are trying to crack that as well. With multimodal images, as you can see, like a diabetic macular edema, along with the fundus, we also incorporate the OCT, diabetic macular edema, exudative ARMD. Again, the same patient's exudative ARMD in OCT. Fundus incorporating it along with the OCT. Again, this is an exudative ARMD. Fundus, you can see we annotated all the findings separately along with the annotation of the OCT. So we are incorporating two modalities, the fundus and the OCT. So this is called multimodal AI, which is something that we at our center, Mahatma Hospital, along with the pioneers of AI, we are also taking some baby steps towards it. And this is our novel algorithm. We do that, and the software cracks it in 60 seconds and tells it whether it's glaucoma, diabetic retinopathy, or whether it's ARMD. So this is again one of the recent publications in IJO showing the same, and there are multiple publications on the same. So I once again thank for the chairpersons for giving me this wonderful opportunity to show my AA on, especially the multimodal AA on diabetic retinopathy and ARMD. Thank you all.
Thank you, Prasanna. By the time Dr. Arun Kshetrapal comes, if anybody has any comments or questions to Prasanna. Anyway, he's setting up. So, Prasanna, what are you practically using daily now in AI?
Sir, currently we are working on the offline apps, sir, inspired from you. So we are trying to make a system that if anybody takes a fundus photograph and feed it into the app, they'll not only get the diagnosis, along with the diagnosis, they will get the signs as well, where there is a hemorrhage, where there is a new vessels. So that adds on to the explainability part of it, sir. So that is where we are currently standing. And we are trying to move to multimodal AI also, sir. In glaucoma, we want to add the visual field, OCT, and fundus. And in diabetic retinopathy, also the same. We want to add more the imaging methods. So more the imaging methods, more the results will be more sensitive and specific, sir. That's where we are trying to work, sir. More of a multimodal AI rather than only diagnosing with fundus. Yeah.
Yeah, Dr. Prasanna.
Yes, sir.
Talk in the first session as well as in this.
You can introduce yourself so everybody will know.
Yeah. About the input.
Yes,
The doctor, or is it the optometrist who gives the input? You were showing somebody has to select.
Correct.
And then that has to be done by the ophthalmologist.
Yes.
And if the inputs are wrong, you were saying that in the general picture,
yes, sir.
Eventually the AI takes over and decides that input was wrong, is it?
No, sir. What happens is, if the inputs are right or if the inputs are wrong, the AI will process it and it will predict it in a certain way. And again, the second layer interface is done by the human. The humans will annotate, the machines will learn, and again the humans will mark whether it is right or wrong. So by marking whether it is right or wrong, when we mark it as right, the machine picks up. Just like a baby, sir. If it does a mistake, we say you are right. If it does something good, okay, right, thumbs up. So like that, the machine learns. If it is marking it wrongly and we tell it, it will note it down. So that is the algorithm for the negative marking. Yes, sir.
Arun, you are ready? Okay.
Thank you, sir. Thank you.
Thank you, Prasanna. Prasanna, you can come here.
Yes, sir.
Thank you, Dr. Prasanna. You have made my task easier. I'll be talking about understanding fine nuances of artificial intelligence and its applications in ophthalmology. So, just a small introduction. AI is basically a field of computer science which deals with the development of intelligent machines, which perform tasks that require human intelligence, such as visual perception, speech recognition, and decision making. Artificial intelligence has improved accuracy in diagnosis, predicting disease progression, and has assisted us in treatment planning. Popularly, AI algorithms are being used in machine learning to analyze images such as retinal scans, OCT, and we have been using algorithms to detect and classify diabetic retinopathy, ARMD, and glaucoma. Overall, it has improved patient outcome and has facilitated in early diagnosis and management in ophthalmology. Image analysis in ophthalmology is an part of AI and has been widely used in glaucoma for diagnosis, progression in evaluation, and preferred treatment selection, as well in retinal diseases such as diabetic retinopathy. We just heard Dr. Prasanna about that, exudative and dry age-related macular degeneration, geographic atrophy, and retinal dystrophies. Then there's another thing called predictive modeling. Predictive modeling is basically analyzing large data sets so that it can identify the risk factors and predict the likelihood of a patient developing a certain eye disease. Artificial intelligence basically has different subfields such as machine learning, natural language processing, robotics, expert systems. Machine learning is basically developing algorithms that automatically learn patterns. So you just teach it once, and then looking at the different algorithms, different images, it starts learning on its own, on itself, and it starts correlating the data among itself. And this is all done without programming the machine, without any program. So you just, as Dr. Prasanna said, that you tell the machine that, okay, this is a microaneurysm, and this is a hemorrhage, and this is neovascularization. So next time when the machine sees that thing, it can identify on its own and it can refine on its own. Deep learning is again a subfield of machine learning and involves training artificial neural networks. It is something like our own neuron system, as Dr. Prasanna has just said, and it is inspired by the structure and function of the human brain. It can learn to recognize pattern in large amounts of data by analyzing multiple layers of interconnected nodes. So it has a big similarity with neurons, as the dendrites, they act as an input, and then the cell body analyzes the message, the chemicals, and then sends the output. So similarly, there's an input involved which is being analyzed, whether it is true or false, or it's okay or not okay, and then the output is given. And similarly, you can have many such layers inside. So basically, deep refers to the depth of the network and may contain hidden layers in it, allowing it to learn complex features. And also, not only learning complex features, but making a relationship between the data. And this has led to significant advancement in areas such as image and speech recognition, natural language processing, autonomous driving. Deep learning and diabetic retinopathy, as Dr. Prasanna said. So first of all, what you do is you collect large data sets, both of normal and diabetic retinopathy cases. Then there's a pre-processing. You remove the noise, you adjust the brightness and contrast, and crop the region of interest, and tell the machine that this is in hemorrhage, this is a microaneurysm, this is hard exudates. So the training is done, and algorithm is trained on a pre-processed image using a technique called CNN, convolutional neural network, and it is a type of deep learning algorithm that can learn to recognize patterns in images. Then this model is then tested on a separate set of retinal images to evaluate performance in detecting diabetic retinopathy. The performance is measured in the terms of sensitivity, specificity, accuracy, and area under receiver operating characteristic, or ROC curve. So this image has already been explained by Dr. Prasanna, so I'll not go into detail again. So you tell the machine that this is what, and then next time the machine starts learning on its own. After all this has been done, then there's a step called clinical validation. The algorithm is validated in a clinical setting about the feasibility, safety, and effectiveness. So this is just a flow chart. First of all, the image is captured, which is pre-processed and then analyzed by the machine, and disease grading is done, and then treatment planning is done. Image analysis and interpretation is of great value in OCT also. How it does, it segments the different layers of the retina, and this segmentation enables more accurate and objective measurements of retinal thickness, volume, and other parameters that are critical for diagnosing and monitoring ocular disease. So after this, it can help us, it can be trained to classify OCT images based on the specific feature pattern, such as presence of drusen in age-related macular degeneration, or presence of macular edema in diabetic retinopathy. AI and image analysis interpretation, it can be trained to, can be used to detect changes in OCT over a period of time in the terms of retinal thickness or volume, and help clinician make informed decisions about timing and type of intervention needed for each patient. It has a role in telemedicine as well. About the telemedicine, I'll come on later. Predictive modeling in ophthalmology, it uses then there's a thing called predictive modeling or predictive model. It predicts what is going to happen next based on the logical points. So it uses statistical and machine learning techniques, predicts the likelihood or risk of developing ocular disease or its outcomes, and it is based on patient specific characteristics, environmental factors, and other variables. Several predictive models have been developed to identify patients at high risk of developing glaucoma, and these models use variables such as age and family history, intraocular pressure and corneal thickness, optic nerve head appearance, to estimate the likelihood of a particular patient developing a glaucoma over a period of time. And it can also help in identifying higher risk patients who can develop glaucoma in future, whereby the clinician can provide early intervention and prevent a delay or vision loss. Predictive modeling has been used in diabetic retinopathy progression, where it predicts the likelihood of diabetic retinopathy progression based on patient-specific factors such as age, glycemic control, and lipid levels, blood pressure. It helps clinicians to identify patients who are at a higher risk of developing vision-threatening complications such as macular edema or proliferative diabetic retinopathy. And then the clinician can provide timely intervention to prevent or delay vision loss. It has been used in ARMD progression as well on the similar guidelines by identifying variable factors. AI has been used in treatment planning. AI can help in treatment planning by providing personalized treatment recommendation based on patient unique characteristics and medical history, and can help determine optimal dosage of medication, appropriate time of performance. It has a very big role in telemedicine. It facilitates remote consultation and diagnosis by analyzing images and other data remotely, and it can also diagnose and give treatment recommendations to patients who may not have access to specialists. It can assist ophthalmologists in making clinical decisions by providing real-time feedback on management and identifying potential side effects. It has helped in research and development by helping accelerate the discovery of new treatments and therapies by analyzing large databases and identifying the patterns in those data sets, and help researchers identify new targets for drug development and optimizing clinical trials. It has certain limitations. There's a need for large and diverse data sets. Potential biases can be there in the data which is fed in the machine, so those biases can be carried forward. And of course, there are ethical considerations that, like, if something goes wrong, so who will be responsible? Whether the AI will be responsible or the doctor will be responsible. Overall, AI in ophthalmology has the potential to improve patient outcome, increase the efficiency of healthcare delivery, but AI should not replace expertise and judgment of ophthalmologists. Rather, it should serve as a tool to assist in diagnosis, prognosis, and treatment planning. In words of Stephen Hawking, intelligence is the ability to adapt to a change. Thank you very much for your patient listening.
Thank you. Hello. Thank you, Arun. Is there anybody wants to have a question, or Dr. Prasanna, you have any comments?
Thank you, sir, for this again wonderful presentation.
Thank
Sir, what is your take on bringing in the human interface into the AI, sir? Because the black box phenomenon is something that is well talked about and well debated. What is your take? I just wanted to know.
You mean to ask that how can humans and AI work together, right?
Together.
So there's still gray areas where basically AI will depend on the data input.
Yes,
The
sir.
data which you give it, if the data is correct, so two things that you need to check the data which is being fed into the AI, and then you need to validate the outcomes of AI. There need to be a person who has to check it. You just can't simply close your eyes and
Yeah.
believe on AI. AI says, okay, this patient is going to progress faster, his cupping is going to progress faster on the various factors, but you need to keep a check. So that's where the humans come in, where
Yes, sir.
you can't do without ophthalmologists.
Yes, sir. And for the benefit of the attendees, as rightly pointed out by sir, in the court of law, again, it's a doctor
Ethical
that is
consideration, yes.
involved, not the AI. So I think we all need to be very clear about that point, that AI will not save us in the court of law, because it's the doctor behind the diagnosis and not the AI behind the diagnosis.
Right, very true.
Yeah. Thank you, sir.
Thank you very much.
Take your time.
Take your time.
Thank you for this wonderful opportunity. I met you in a lot of words for
Yeah, first time you've meeting.
Yeah, thank you. Thank you, Arun. I think the other speakers, I hope they will join us. So this session is everything real about the unreal AI in ophthalmology. And you listen to both Prasanna and Dr. Arun Kshetrapal. So I am speaking on smartphone-based app to diagnose diabetic retinopathy. So here you see a normal looking retina and a retina affected by diabetes, because the diabetes mellitus is now the epidemic of the 21st century. And diabetic retinopathy is a major cause of blindness in the working middle-aged adult population, and the fifth cause of blindness globally. And the IDF Atlas 10th edition 21 provides the latest figures, information, and projections on diabetes worldwide in 2021. Approximately 537 million adults between 20 to 79 years are living with diabetes. The total number of people living with diabetes is projected to rise to 643 million by 2030 and 783 million by 2045. 3 in 4 adults with diabetes live in low and middle income countries, and almost 1 in 240 million adults living with diabetes are undiagnosed. And this is a world problem. And more than 1.2 million children and adolescents between 0 to 19 years are living with type 1 diabetes, and 541 million adults are at increased risk of developing type 2 diabetes. The problem, conventionally, retinopathy screening is done by fundus examination by ophthalmologist using conventional fundus by optometrist or trained eye technician. The primary issue in India is we have only one ophthalmologist per 100,000 population, which is published in the Indian Journal of Ophthalmology in 2019. 70% of Indian population resides in rural area or urban slums, And low awareness or ignorance, it's a problem. And we are working on the patients walking into the OPD. If you ask a patient with diabetes, they don't know that the diabetic patient may go blind or may have retinopathy. Thirdly, follow-ups are required for years together, because diabetes once sets in, it is up to the grave. And the technical difficulties in India we face using AI is unreliable internet coverage, because you need internet for the source, as Dr. Arun Kshetrapal mentioned. Unless you have data, correct data with the correct matching details, then the AI will not be accurate. And the deficit in supply of electricity in many areas, and a shortage of trained medical staff for operating conventional fundus camera, and portability of fundus camera. And the solution, these issues can be solved using computer machine learning. Just now, Arun Kshetrapal mentioned AI for analysis of retinal images in people with diabetes, thus solving the at least some part of the problem. This is again published by Dr. Atul Kumar and team. And this definition, I like the AI, the way forward. Intelligence is the capacity to analyze, think, make a decision, and categorize. And that's what, like the common sense is commonly not available. And people have, they don't use it. The artificial intelligence involves formulating a specially made algorithm according to our needs to develop this capacity and include it in an electronic device like smartphone. So the role of the AI system, integration of retinal photography and artificial intelligence, AI-based grading and diagnosis system for referable diabetic retinopathy, performs the following procedure fully automatically. That means you don't need a person to do it. Identifies fundus features, classifies image quality, classifies the existence and severity of the disease, and all these are based on deep learning technology. That means you keep on feeding the computer with images, with the details, and say this is normal, this is background diabetic retinopathy, proliferative diabetic retinopathy, diabetic. So it picks up the features, and that's how AI, which Google found out the retina belongs to a male or a female. I don't know what's the application, but that can be found whether it belongs to a male or a female. And we have no way to find out as a human when we examine a retina photograph whether it belongs to a female or a male. So the way to go, and this is what I learned from the cancer people, where they have to screen, diagnose, and treat. Because if you don't, if you only screen and diagnose and then leave them without treatment, and I think that's a sin. And particularly in cancer, now in India, it's punishable. That means if you are doing a cancer screening camp, and if you see that you screen and diagnose and don't take the patient for treatment, and you are punishable. So that means whether the money or not, whether the patient can afford or not, whether the patient is aware is not the question. If you do a screening, you need a counselor to convince the patient, for a cancer patient, to go for treatment. Otherwise, they say don't do the screening, because if you screen, diagnose, and leave them, in particularly in diabetic retinopathy, we can have patient can go blind, not may go blind. And the second, we found in the Smart India study by Dr. We have a lot of speakers not come, so we will do that. Thank you. So, in the Smart India study with Dr. Shobha Shivaprasad, Dr. Rajiv Raman, and Dr. Kim, and 20 centers in India, we found we have vision-threatening diabetic retinopathy, and the patients are not willing to come for treatment because they have 6/6 vision with advanced proliferative diabetic retinopathy without macular edema, and they need laser treatment or injection. Unfortunately, they don't want to come. They are afraid that by treating you lose the eye. So that in India we have another problem where after diagnosing, and there are a lot of NGOs available for doing treatment, patients don't want to come. And so that's why unity is his strength. We need more working hands, and we have to make use of minimally trained staff already available. We arm them with AI to bridge this gap. And as Dr. Prasanna said, the AI cannot replace doctor. So many times people think AI is going to replace. Even though in the Tesla car you can drive without a driver, but I think you need to we have to be there and make sure that things are working well. I mean, even in the plane, you have autopilot, and plus also the various computer landing systems, the CLS. But still, you need the pilot to be there to manage the weather disturbance happening. So the role of doctor is never going to be go away. And I always tell, whatever computers have come for even hospital management software as well as now the AI, still you need to touch the patient. That means you need to treat the patient with whatever injection, laser, surgery, and for that you need to touch the patient. And that's important because the human touch, I call, with the high touch, that is the technology also. You need to be a good human, and because you're treating another human being. So we have this pre-camp awareness, which we do it in entire slum of Mumbai, assembly of diabetics, capturing of the images and uploading. Either we use, right now we are using the ophthalmologist, we use AI, we also use optometrist trained, and also image graders. And this is the thing I'm suggesting as a AOS president in 2019. This is what I wanted for the entire India for doing the nationwide screening. So you have the AI, machine learning, deep learning, and then we have the explainable AI. So there is no financial interest. I am working with Remedio, where our hospital, our foundation, in my parents' name, Kamala Sundaram Foundation, earlier known as the Aditya Jyoth Foundation for Tinkling Life, has published first of its kind world project for the screening of diabetic retinopathy using of a non-skilled worker. That means any school dropout, we train them and make them a semi-skilled health worker. That means one skill is to use the fundus camera, either using the mobile or that 4S, and an AI deployed on a smartphone, non-mydriatic retinal camera, and we are doing that in the municipal dispensaries in Mumbai from 2017. And the computer is trained to accept retina pictures properly taken by the trained semi-skilled worker, compare it with the thousands of previously provided diabetic retinopathy pictures, which is there in the mobile phone, and based on that, notify the staff which patient needs to be referred to ophthalmologist labeled as referable diabetic retinopathy. Thanks to the media software from Singapore, which now has been taken over by Remedio, which we incorporated the AI in the mobile phone. And the Remedio fundus camera on phone can be mounted on a suitable bike for transporting for screening purpose. Like here, you see, you can use it as a handheld, but I like the patient to be stable, and the examiner or the semi-skilled worker to be stable, so that you can have the chin rest, and then it's cost little extra money, where it can be mounted on any table. The advantage of using the system is, I don't have, as I said, financial interest. There is the mobile phone can be charged, and the infrared device can be charged. And we started this in thanks to K. Chandrasekhar, who's the CEO of the Forest Camera, and again, no financial interest. I gave him the idea in the Agra All India Ophthalmic Conference in February, and then in March we inaugurated. You can see that time the 95-year-old grandmother with my father, late father, who inaugurated along with my best friend Shivanandan, who's there supporting all my services, where we carry the Forest camera in the motorbike, and nothing happens because the optics are kept you will be seeing in the video. So here you'll see the boy carrying the optics in the backpack. That means it'll not shake when the bike is moving, and that's our main hospital. From how we just keep the fundus camera in the box, and then kept it in the which is there in the carrier in the motorbike, and you can see he's carrying the backpack which has the optics. And you can see the road. This road is okay, but when you have a bumpy road, and nothing happens to the optics. And this is where we have a clinic in the slums of Mumbai in Dharavi, and we have taught him to assemble and reassemble. And you can see he can take beautiful pictures. And like this, we have trained. This boy is only a 10th fail or 9th pass, and this is an optometrist intern who's being trained. So this is using the Forest, and even Forest now has come out with the AI software for diagnosing diabetic retinopathy. So I think we can So I use anybody can, all of them no need for any education, whether they can read or write. Even if they can't read, all of them you know in India to use the smartphone. They may have the simplest smartphone, that's enough for them, and you don't have to know English. So thanks to Dr. Parul Datta from Shroff Charity and All India Ophthalmic Society, we actually signed an MOU in 2019, and then we implemented in 2020 in Gurgaon conference. Unfortunately, post-COVID, the MOU is not renewed with the Skill Development Corporation of India, which is a semi-government located in Delhi, where we have got a curriculum where we can train 3 weeks these people who are literate or illiterate, where they need to use only interest for using the smartphone and also use diabetes. So I call this as a ABCD. From that, anybody can dance to anybody can diagnose, screen for diabetic retinopathy. So these are the various stages of diabetic retinopathy. For the boy or the girl need not know the details. So there is the image capture done by a non-specialist or anybody, and a analysis of all images done by the AI. The sensitivity for detection of referable diabetic retinopathy continue to remain 100%, while the specificity dropped due to non-diabetic retinopathy images being graded as referable diabetic retinopathy. So this you can see the capturing the fundus photo with the smartphone, and we have trained our health workers. And this is the Remedio camera where we are put to use. You need a dark room, and that's available anywhere in the slum, and you can see the boy or a girl can make the photograph like this, and this will now he can put it on the media software, and then it'll say that you can see that it's a 99% confident. That means that picture is good. And then you see the blue thing, which is the one which identifies the color difference, and that's the AI which analyzes and say referable or non-referable. That means if you go to a camp and detect diabetic retinopathy, and you don't, the boy or the girl need not know anything. They only have to put that image and put it on the AI, so you can see the 99%, and there's the signs of detected diabetic retinopathy, and then you can see the referable. So this is the fundus on phone compared with the Zeiss camera, and the economic, it is cost-wise cheaper. So I am actually trying to do this in Africa and also South America. But first, I want to do the entire Kashmir to Kanyakumari and Arunachal Pradesh to Kutch. So this is how the example of the various stages of diabetic retinopathy. The blue is actually detecting the abnormal color, and then with the stored images, the AI detects the patient is having PDR or PDR with the CSME, and then it says referable and non-referable. So this is a link between medically underserved area and tertiary healthcare services, and particularly I think you can send the images anywhere, and it's already there. And that's as a president of All India, I made this Jot Jalao called the screening through teleophthalmology for prevention of diabetic blindness. And the same auditorium in 2019, as a president of All India, there was a movie made, which is there in the YouTube, where it was in the International Advertising Association India chapter, where we conducted a competition and made a diabetic retinopathy awareness, and about 4,000 times it was screened in the national television. We also did this in using with the Remedio staff and our foundation staff. We used 13 fundus on phone devices like this, and we came on the Guinness record, where we have 649 diabetic patients were screened using fundus on phone. 53 were diagnosed with diabetic retinopathy. We want more and more people to break the record. The idea is to create the awareness all over India. And this is the Guinness certificate. So this is again, I am into this from 2019, and so we had this research question: is AI reliable to pick out those in need for seeing an eye doctor? And that was the result. An ophthalmologist found 15 patients with referable diabetic retinopathy, and AI also marked these patients as referable case for diabetic retinopathy. So reliability using this media software and Remedio for screening DR in need of ophthalmic checkup by an eye doctor is 100%. And this was published in the JAMA the diagnostic accuracy of community-based diabetic retinopathy screening with an offline AI on a smartphone, and that was the most talked about articles in 2019, ranking number 5, and around there were in a month also. And we further did more patients and published in Indian Journal of Ophthalmology, and that's the conclusion, where despite including poor quality images, the sensitivity and specificity of detecting referable diabetic retinopathy AI were 100% and 89.55%. And we also work with the diabetologist, endocrinologist, because diabetic retinopathy awareness and association with multiple comorbidities. We made a publication on this diamond study. And the advantages of using AI: early referable diabetic retinopathy, greater awareness about diabetes, its effects, and importance of regular follow-up, greater chat time for an eye doctor to see the patient. That's what finally, as I told, we have to touch the patient to make sure the patient is all right. Timely medical surgical intervention to prevent complete loss of vision. More job opportunities. It means in UP, you don't need a Romeo police. We can probably train them to do fundus screening, because that's my dream. We have we have to create more job opportunities and still development of less David. And I'm very impressed with this girl who's now maybe 22 or something. And in 2014, the National Eye Institute asked me whether you can help this girl. She, at the age of 16, got initiated into AI, and she first studied the effect of retinopathy on her diabetic grandfather living in coastal Andhra. But she's born, brought up in US. She studied in the Jefferson High School, which is different from the regular school, with promoting science and physics. She then developed eye agnosis, a diagnostic tool and app on the smartphone, and we did the testing when they wrote to 5 institutions, and I took that. And you can Google her, and I'm very impressed with an Indian origin person, but she's a second generation American Indian and now unfortunately she shifted from eye ophthalmology to neuro, and she's using AI in neuro. And with all this, because I thought after finishing my president post as a All India Ophthalmic Society, I was wondering how can I continue this project. But during the year as a president in November, we did about 4,000 camps, because and we made noise with all the states of India and union territories. And after 2020, I thought, how can I keep progressing? So I made a Section 8 company called an NGO, Sundaram Natarajan Blind Free India Foundation. The dream is to make India blind free and eliminate diabetic retinopathy, eye ailment, the diabetic retinopathy. And our objectives we used to do on many things in ophthalmology, but I am concentrating on creating at least awareness of diabetic can produce eye problem. And there are 6,47,745 villages in India, and we only have 30,000 ophthalmologists and maybe 10,000 or 20,000 optometrists. So how do we reach every villager? We have formed this foundation to access all the villages. We are training young people and creating job opportunities across country. And we can train semi-skilled person to use the offline AI. Any company, I don't mind, or Remedio to screen diabetic retinopathy. And this is what I mentioned about the Romeo police.
Sir,
Yeah.
please conclude.
Oh, yeah.
Yeah.
Hello, Aaron.
Yeah.
And I'm the last slide. So my idea is to diagnose diabetes early at the age of 35, so that we can prevent all this, so that it will not cost the government or the person to die of either a renal failure or a heart attack. So even Dr. Arun Kshetrapal spoke about Stephen Hawking. He says AI is likely to be the best or worst thing to happen to humanity. It is up to us which one it's going to be. So world, this is the one which we made in the movie. World will forgive you. Will you forgive yourself if you have diabetic blind? And diabetic blindness is preventable. If you are diabetic, you need a retina checkup to prevent vision loss. Thank my team. Thank you very much for the opportunity, Arvind.
Thank you, Dr. Natarajan, for such an elaborate talk. Are these cameras non-mediatic, or you need to dilate the pupil? The Forus and
No,
the Remedy?
45% you can do non-dilated, and the rest of the 55%, which they based on the NHS study in UK, where they have done in millions. 1% tropicamide. After 10 minutes, you can take all
slightly more than
Yeah.
3.5 millimeter.
Correct. It will become 3.5 to 4.
Okay. And how much far are we in developing a laser delivery system which can identify the disc, the fovea, the macula, and the vessels, and it can treat the diabetic retinopathy? Are we doing something about this? Is
For the laser,
research
you're
going
saying?
on there?
No, there's a system. No, I forgot the name of the company where you can set everything and it will do the laser.
It will do the laser.
Yeah,
I
so
see.
it will identify the fovea and avoid
Yeah.
the fovea.
So once the clinician validates that this is a case of a diabetic retinopathy and
Right.
needs a laser,
Yes.
so you can ask the patient to say.
Yeah, but in India we have so many ophthalmologists still.
But still we are running short
and
of
again everything is going to cost. No.
So India is going to be the world capital of diabetic
Yes.
retinopathy in 2030, and we'll need many more screening
Correct.
people to decrease the workload of ophthalmologists.
That's my dream. So that's why I made this foundation where every diabetic should be screened. We have, I think, 77 million diabetics as per IDF. 40 million do not know they have diabetes.
Yeah.
And that means 4 crore people. We have to make sure you do the HbA1. That's what I'm trying to propagate everywhere. We do the HbA1c, do the whatever the fasting and random sugar as an eye foundation, and also detect retinopathy and make sure they are treated free. So I'm doing, but like in Madras, I'm doing with Shankar Nethralaya and Dr. Madhivanan and other places, whoever is willing to join. Because I don't want to create a hospital. My idea is to create awareness and make funding available to all the NGOs all over India.
Yes, I remember way back, like in 2004-5, we had started doing these
Yes.
camps when we were having our LDP sessions.
Correct.
And you motivated me to also conduct a camp, diabetic screening camp.
Yes.
Thank you very much. Are there any questions from the audience? Are there any doubts or somebody wants to raise a concern? Thank you very much.
Arvind can give a comment. No? I said Arvind can give a comment.
Yeah, Arvind.
Yeah, means AI is definitely there for all the ophthalmologists. So we need to imbibe it, this new technology. It's very useful in the diagnosis and especially for the progression of disease like the glaucoma, the diabetic retinopathy. It's very useful, as sir has rightly said in his talk. Thank you so very much.
Now I call upon Dr. Rolika Bansal. She'll be talking about AI in corneal conditions.
Yeah.
Please
the
go ahead.
Top. Yeah, perfect.
Arvind, you are the chairman of this program. By the time the slides come, you can introduce yourself and.
Yeah, sorry.
So I welcome you all for this wonderful session on everything real about the unreal artificial intelligence in ophthalmology. And I would like to welcome Padma Shri Professor Dr. S. Natarajan, who is a doyen of ophthalmology, international figure, and he has done a lot of work in the field of diabetic retinopathy. And I would like to welcome Dr. Arun Kshetrapal. He is a prolific surgeon from Ajmer, from my hometown. And I would like to welcome Dr. Rolika Bansal, who is a young champion in the field of ophthalmology, winning all the awards. So, and myself, I am professor and head at All India Institute of Medical Sciences, Hyderabad. Over to you, Dr. Rolika.
Right. So just a disclaimer that I'm presenting this presentation on behalf of Dr. Modini. This is absolutely her work, and since she couldn't be here as she had some prior commitments and travel issues, so this is her presentation and absolutely hers. I'm just speaking on her behalf. So I'll be talking on the AI component on cataract and glaucoma component as well. So as everybody has already quoted, artificial intelligence in ophthalmology could be either traditional machine learning or deep learning. And when we talk about deep learning, it is basically self-learning from the secondary sources, which could be either in the massive training artificial network form or the convolutional neural network form. And traditional machine learning has been explained very well over here, and that would be on model for diagnosis for ophthalmic conditions. So as you can see, it's a beautiful chart where it shows that a traditional healthcare system, one ophthalmologist can cater to 4,000 people in a year. However, when we integrate the traditional healthcare system and the AI-based tertiary referral system, as Dr. Natarajan sir has very beautifully shown with his Forest example, when we combine that, we can actually serve more than 40,000 people per year. That is a 10 times increase manifold. So, artificial intelligence is a way of making a computer, robot, or software think and act like a human. This is very well known. So, we have to understand that we have to also make sure that we are doing good in the process. It should not be an erroneous diagnosis as well. The theory and development of computer systems is able to perform tasks normally requiring human intelligence, such as visual perception, speech recognition, decision making, and translation between languages. So, it is basically the use of computer system to perform tasks which are normally associated with human intelligence. As you can see over here, AI has enabled virtual assistants, and it is reducing unnecessary. Just one second, there's some echo coming. Could you please help me out? Yeah, that's fine now. It's still echoing, but okay, I'll go ahead. So the AI-enabled virtual assistants are basically reducing the unnecessary hospital visits. It is giving 20% of time back to the nurses. We are able to help them out. The workflow assistants are also helping doctors free up 17% of their schedules. And we all know that we, even as ophthalmologists, have quite a working hectic schedule. Pharmaceutical companies are researching life-saving medicines in a fraction of time and cost it traditionally takes. We have been able to bring healthcare to underdeveloped nations, and in a developing nation like ours, we are able to reach out to more people. And the cause of blindness in India, as known, 62% is due to cataract, and refractive error also holds a very high stake. And so it is important to cater to the same. As you can see over here, there is a triple module. There's a prediction module wherein the prediction metrics we are able to analyze. There's a dispatching module, and there's a telehealth module. Telehealth module is where the patients that need intervention are screened. And over here you can see that the rescheduling of after intervention is also taken care of, so the patient really actually gets a reminder, or like an individual follow-up plan that they need to come back and have a follow-up. So that also helps. So as you can see over here, I would again highlight that sir has beautifully shown how diabetic retinopathy can be screened by the software that they are using. And over here, AI-based cataract screening can also be done. So we can actually cater to a larger community by the AI-based screening. And over here, you can see that the identification network in a large population, one can assess that, okay, there are 3 particular eyes which require or might require an intervention. After that, there is an evaluation network where using the cruiser intelligence, you can compare and do a risk stratification at which particular patient requires an intervention sooner. Then there are strategist networks wherein you can actually categorize considering the area, density, and the location that these patients require surgery or the ones which require follow-up. At the same time, in the evaluation of IOL power over here, you can see that AI has played a major role in assessing the IOL power either by the optical formula or the machine learning formula, and it has turned out to be useful and more precise, as I must say. So it is improving the accuracy of biometry. So you can see over here that multiple machines that are required by an individual, by all of us, has actually been combined to a blade-less femto laser with artificial intelligence, and that makes our life easier. Isn't it very difficult to buy n number of expensive machines, putting it together in one with more precision? Over here you can see that supervised machine learning algorithm, it basically means that there is a classifier, there is a cross validation, and a performance measurement. Also, you can see that these are the basic programs which have been able to identify the errors which are being made. So here, the novice surgeon, who is learning to do phaco chop, has been able to assess whether the hand position is correct or not, the holding of instruments. Here you can see the eye is not in primary. The safety with the cannula use. The surgeon is not really holding the hub of the cannula. So these can be identified and these can be corrected. So you can actually put your surgeries through and assess whether you require any change or not, which can be covered by artificial intelligence. So over here you can see that there's an initial grouping and a refractive error like myopia. So myopia screening is done. You have established the files. You've done an AI analysis. You've done a progression risk stratification. And then there's a continuous management. It doesn't end here. The patient continuously keeps getting an AI-based analysis. Over here, you can see that multiple formulas are required. We've all had these formulas, we're aware of them. However, the artificial intelligence based formula, that is Clark Neural Network or Hill RBF calculator, also exists, making it as easy as possible. And another example is when you have to assess the disc status in glaucoma patients. It has been shown by Sir previously as well that the fundus photo, the OCT imaging, and the perimetry imaging, all of that have been put into the AI algorithm, which can be classified into likely glaucoma, not classifiable, or not glaucoma. And you can see here the LayNet architecture, that is the particular software wherein the ROI extraction is done, the optic disc and optic cup segmentation can be assessed in the unit model, the feature extraction can be done in the more higher models, and then the classification can be done in glaucoma or in healthy disc, as seen over here. You can see that the cup height and the disc height can actually be very well compared, and you can assess whether the patient has glaucoma or not. So this is major screening that we are looking at. And also the error correction can be done by AI. So the noisy OCT imaging can be denoised, and we can filter out the artifacts that can be seen. So as I have explained earlier, that the data acquisition, the data processing and analysis, it can be done along with feature extraction, however, followed by the pattern classification, and then decision about whether it is normal or glaucomatous. As beautifully explained by Sir, that the diabetic retinopathy component has also been very well assessed by artificial learning. So all I can say is that artificial intelligence cannot really replace human intelligence, but artificial intelligence can surely reach where human intelligence cannot. And Professor Natarajan has shown a very good example for the same. Thank you.
Wonderful, Rolika. Anybody wants to question or comments? Arun? Can you be ready now? Next is yours.
It would be good to see artificial intelligence helping us in especially the biometry, because I feel that the biometry is a very important part of cataract surgery, and most of the errors which creep in. So, where do you think the artificial intelligence can help us in biometry?
I, in fact, feel that the assessment by artificial intelligence is going to be more precise in biometry than the human uh, assessment, because of course there is more chances of errors in human assessment than artificial intelligence assessment in biometry zone.
Not only that, I feel that by just looking at the A scan, the AI should be able to tell us whether this A scan has been done properly or not, or it needs to be done again, or something like that. I
Yes.
think there's one field where it can help us in. And wonderful talk, Dr. Rolika. Thank you very much.
So again,
Arvind,
courtesy
you
to
want to make a
Dr.
comment or
Modi.
something?
Yeah, means I would like to quote one AI-based means application that can be placed over the glasses, and when we are doing all our daily routine work, so that it decides which type of intraocular lens should be implanted in that particular type of person. So AI has definitely evolved, and it is helping the ophthalmologists and helping in the cause of serving the mankind.
Thank you.
No, I
Thank you.
think as you everybody mentioned, I think you also, Rolika, mentioned that it's not going to replace doctors, but at the same time, definitely we should, any technology, I think, whether it's a phaco machine or a vitrectomy machine or a car, we have to be the master, and we should not be a slave to the technology. We should know to use them. I mean, there are robotic cleaning available. It's all AI based,
Yeah,
which cleans.
definitely means I believe, personally believe, and I've worked in AI also. We have developed a few applications. So, whatever we are developing, it needs to be supervised.
AI should not replace the judgment of ophthalmologists, but it should rather assist the
Yeah,
ophthalmologist in judging and
definitely,
deciding. Yes.
definitely.
But here you are using AI where even a illiterate, I
Yeah.
tell them any sweeper we can train them. Instead of only doing that, he can do the retina. He can take photo and then the AI will do the thing.
The AI
Treatment
will
will be
do.
done by the doctor.
Yeah.
So it's we can use the technology to the
As an
every
assistant to
human being in India.
ophthalmologist.
Good morning, welcome. Yes. our Dr. Arvind Kumar Maurya, an energetic young professor, to talk on the AI. And the whole session is conceived by him.
Good morning, everyone, and thank you, sir, for your kind introduction. I would like to thank Professor Dr. Modini Pandharporar for giving me the opportunity. She was not able to make it today. So my talk is on smartphone-based applications which can be used and which are used in ophthalmology. So these mobile-based technology, definitely they are the future of telemedicine, and they help in the outreach activities which are centered around the home only, and especially the visual acuity and the visual field screening applications are there, which are capable of detecting visual degradation even before they present to a healthcare professional. And the patient feel more engaged and improve their compliance. And these smartphone applications are capable of improving the disease outcomes. So right now there are more than 700 applications with eye care themed, in which 259 applications are of some or the other use for the general healthcare, and 131 applications are relevant exclusively for the ophthalmic practice. Regarding the cost effectiveness, 76% of the applications are available for free, and about 22% need a monthly or annual payment. And in about 2% of the applications, the developers have provided a free trial of about 2 weeks. So these are the distribution of application as per utility and operating system. So the topping in the chart is the vision screening, then the eye exercise, professional education, etc. Regarding the reviewer rating and validation, so 13 applications had more than 500 reviewers, all designed for the non-eye care professionals, including the eye test application, designed for general public largest number of reviewers rating. And the application with maximum reviewer rating is Smart Optometry app with 50,000 downloads and 680 reviewers. Regarding the validation, that is a very important aspect, but unfortunately, only 4 apps are claimed by the developers to have undergone some validation test. And 3 applications were designed by the eye care professionals without any involvement of the developer. And 10 applications were endorsed by the eye care professionals and the healthcare institutions. My Vision Tracker MVT is the first ophthalmic application which has been US FDA approved in 2014. So we look at the mind map of the smartphone application. So it is not limited to the ophthalmic education. There are a lot of applications which are there for the patient education. Then there are calculators. Then there are low visual assistance and of course vision screening. So these are the important applications. So first is the Peak Acuity app. This is a highly validated application. It is developed by the International Center for Eye Health, Department of Clinical Research in London. It is capable of accurate and repeatable acuity measurements in either set in the elderly population, and is an efficient tool for the school screening also. Then comes the Ophthalmology Guide. It is a well-organized and topic-oriented e-book application. So there are systematic details of every topic and subspecialty, including latest ophthalmic instruments. So there is a clear categorization, makes very convenient for ophthalmologists, and it finds the specific guidelines accurately and quickly during our busy time in the clinic. Then comes the iTube application. It is a global ophthalmic video pool. It collects professional videos specifically related to ophthalmology, and aim of providing the ophthalmological education and surgical videos with free access. And it is a time saving indeed. Then comes the Community Eye Care application. It is a free online and offline access to the peer-reviewed articles. It aims to improve standardization and enable easy access to eye care knowledge for all categories. Then there is this eye-hand book application, which is used for diagnostic and treatment reference. So it is a one-stop shop for multiple needs of ophthalmic practice, and it offers a dozen features for both ophthalmologists and eye care workers. Then there is this Smart Optometry eye test for the professional application. So there are various vision screening tests, including color vision, near vision, test for amblyopia, Worth for dot test, Hirschberg, and Amsler grid. It is available in 11 languages in both Android and iPhone. It is faster, easier, and results are very accurate, reliable, and clinically validated. Then the MVT, it converts the Apple smartphones into a medical device. It tracks the progression of vision damaging disease such as ARMD and diabetic retinopathy, and patient test data are automatically uploaded to a physician's portal for monitoring. Then comes the toric IOL axis marker developed by Dr. Girish Jetwa and Dr. Mukesh Dholakia. So it helps in calculating the angle needed as we need to implant the toric IOL. Again, iToric Patwardhan developed by Dr. Saurabh D. Patwardhan. It also helps in getting the accurate alignment of the toric intraocular lens. Then when the North Indian, the residents or the ophthalmologists, they are going for their DNB or different courses in South India, so they are unable to understand the language spoken by the patient. So there is this wonderful application, I Know Tamil, I Know Bangla, developed by Dr. John Davis Akara and Dr. Anju Kuriakose. So it converts whatever the patient is saying into Hindi or English or in any language. And it is absolutely free. Then for the blind people, visually impaired people, so this smartphone application, it reads any paper and it converts into the English or Hindi for the blind patients. And this is also application is free. Then comes the Vikas. This is a visual intervention kit with analytics for the spatial children, like the patients with cognitive visual function and the autism and the patients of cerebral palsy. So this Vikas helps in improving their quality of life by doing the visual exercise, and it is also available free of cost. Then Oglecam for the medical records is developed by Dr. Sunil J. Meravade. So requirement of installation is smartphone with Android operating system 5.0 and up, and it is a one-shop platform for the teleophthalmology consultation, and it also helps in the referral smartly. So in the future and conclusion, concerning the professional educational apps such as the Eye Handbook and Eye Emergency Manual app, institutions or individual could endorse and make suggestions. Applications dedicated to professional use must also be peer reviewed. That is missing in most of the applications. Only 4% of these applications are validated. So these needs to be peer reviewed and validated. Studies are needed to understand the readiness and concerns of eye care professionals in adopting the mobile health. Guidelines to choose an appropriate applications are suggested, and importance of interdisciplinary collaboration in the design, development, and validation of applications must be there. Thank you so very much.
Thank you, Arvind. Any questions? Or we have 10 minutes more. Any suggestions or comments? Anybody using AI in the audience?
How are you using that in what form? Yeah.
Mike, please.
Name's Adam Wax. I'm a researcher from Duke University in the United States. Biomedical
Mic is not on.
Sound, please.
Hello?
Yeah, you can hear.
My name's Adam Wax. I'm a researcher at Duke University, Department of Biomedical Engineering. We use AI in a number of applications, including denoising of OCT images, which I found interesting in the previous talk, but also to identify things like Alzheimer's disease and OCT scans. I want to echo the sentiments that I've heard from all of the esteemed colleagues here that AI has a good role in helping physicians identify disease, but that there is the danger that if we rely too heavily on AI, it will not do as we expect, because it will not be able to accurately identify the abnormalities that we see, instead think that they're just imaging errors. So we will always need the human in the loop to be able to identify those. Thank you.
Talking about the imaging errors, I think you're talking about those, right? So we need to train the system to identify those errors and pre-process the images before it is fed into the system. That will basically involve training of the machine. Yeah.
It's a very pertinent question asked by you. So there are a lot of digital data in the field of ophthalmology. So many of these images are not gradable. So how to make them gradable? So there are a lot of applications which are AI based. So number one is they reduce the size of the pixel of the image, but keeping the high resolution image intact. Number two, so they can make the images gradable by uh, adjusting the contrast, the brightness, and red free image. So most of the images they can be graded by the ophthalmologist. So there are a lot of applications AI based. But not every image can be graded, of course not.
Anything the audience would like us to discuss? Any queries? So Arvind, what do you see in future? How our work will be affected by AI? How our practice will be determined by AI?
I think when the computer came, so we were very much apprehensive. So finally, everyone is using the computers, the smartphones. The first supercomputer was at NASA was 10 room, was kept in a 10 room facility. But now the present smartphone, the Apple iPhone, is processing everything, all the digital data 100 times faster than that supercomputer. So we need to understand that AI will remain there in the life of the ophthalmologist as well as everyone. So we need to accept it as a part in helping the treatment of the patient in diagnosis and especially in the era of the COVID. So there we can't touch the patient cannot come to us. So these applications helped a lot in giving tele-ophthalmology consultation and giving them the best treatment, especially in the follow-up sort of thing.
Follow-up and progression of the
Yeah,
diseases, yeah.
definitely.
So where the humans can miss a lot of things, the AI will be able to
Yeah.
identify and tell us, going to assist us.
Humans are there to err. We may get tired sometimes, so we might miss the fundus finding in the periphery. But these applications, they will be honest all the time.
And what's your take on the concern shown by very lot of people regarding AI? Recently, I think Elon Musk and guys have shown concern that AI is going to not cause, but it may be very detrimental to the humanity. Do you agree to those concerns?
Partly because AI cannot replace the human touch. Our emotions, the way we are talking to the patient with that empathetic attitude. So AI definitely lacks that. Definitely it lacks.
Yeah. Anything else we want to discuss, or we call this session off?
Natarajan sir, concluding remark.
Okay, I think as I said, the concluding remark, the AI will have to, we have to use them, yeah, whether we like it or not. Anything like there are side effects for like the alcohol and drugs available, and when you go to US, you have the gun problem, and you have to face it. So I think there will be good and bad, as Stephen Hawking said. It can either destroy or can create. But I think we as ophthalmologists, whatever Elon Musk and other people are telling, I mean, there are a lot of things happening in the world, but I think we can, for ophthalmology, learn to make that as our as like a
Used to our
assistant
best.
to use it, so that a lot of regular work where in a routine or a repeated tasks by an eye doctor can be replaced with AI, so that you don't miss a finding. And as Dr. Arun Shetar was asking about laser, it can say that you are now focusing at fovea, so for the beginner it will be good. But I think AI will definitely be an excellent tool to assist us, and it's going to be lot of things are going to happen during this time. So I think thanks for the session, and thanks to Partha here for asking to have a AI in ophthalmology. And I think there is a lot of funding for AI research in ophthalmology, and there are several sessions in RO this year conducted by the National Eye Institute and Dr. Tin Wong from Singapore and Dr. Daniel Ting. They are working a lot of things on AI. So even in research.
So, because the concern is, sir, that not all the applications are validated. Only 2 to 4% of these AI applications are validated. So, what is your take on this important issue?
So one is in my practice, I'm still doing both manual and AI, and so far the referral diabetic retinopathy, which is what we are important, where we are concentrating, where treatment required patient should not be missed. But the other things there are mislabeling happening, which we are okay with it. So I think we have to be careful, as you correctly said. Any technology, we have to be careful.
So it needs to be supervised, sort of, not
Definitely.
semi-supervised?
Yes. Definitely you would supervise.
Until
Thank
it
you, sir.
becomes perfect.
Yes.
Until it becomes perfect.
Yeah, definitely.
Yeah.
So we conclude this session, and I would like to invite all the speakers for a group photo.
Thank you very much.
Okay. So who's
Thank you.
taking?
We have our own.
The scientific committee looks